All right, good morning and welcome to Pediatric Grand Rounds. I want to remind people to submit your questions or comments for the speaker into the chat section. We'll have time at the end of the talk for these questions after the presentation. And after the meeting, you'll get an evaluation from the CME office. Please take a minute to fill it out. This really helps us improve our program and maintain the accreditation for this education. And one last note, the planners for Grand Rounds do not have any relevant relationships to disclose. Our guest speaker today is Dr. Rebecca Runsley from Seattle Children's Hospital and the University of Washington, where she is an assistant professor of pediatrics. She received her Bachelor of Science from McGill University and then went to medical school at the University of Toronto. She subsequently completed a pediatric residency, a fellowship in endocrinology and diabetes, and a fellowship in oncology, hematology, and bone marrow transplant at the University of British Columbia. She subsequently completed a pediatric neuro-oncology fellowship at Nationwide Children's Hospital, where she focused on early phase clinical trial development, and then was recruited here to Seattle in 2022. Clinically, Dr. Runsley is passionate about improving the care for children with brain tumors and has a special interest in patients patients with endocrine complications or comorbidities of their brain tumors. Her research program is dedicated both to survivorship and morbidity reduction for patients treated for brain tumors and in studying novel therapies for difficult to treat patients. She serves as the study chair for our local brainchild, our chimeric CAR T-cell study, and is involved in clinical trials nationally and internationally dedicated to children with pediatric brain tumors. She's also committed to trainee education and serves as the program director for our newly created Pediatric Neuro-Oncology Fellowship Program at Seattle Children's, and education lead for the brain tumor team. So welcome, Dr. Runsley.
Thank you so much, Doug. So I have no conflicts of interest or disclosures that pertain to this presentation. I hope to talk about a few things today within the realm of pediatric brain tumors. So the first part of my talk is going to be looking at a tumor called diffuse intrinsic pontine glioma, or DIPG. I'm going to use a clinical case to explain some of the common symptoms, radiographic features, and current treatment strategy. And then I'm going to describe some of the ongoing biology-driven innovative therapies that are currently in existence for this tumor, and then our Seattle Children's Hospital Phase 1 CAR T-cell program. The second half of my talk is dedicated to my other interests, which is in survivors of pediatric brain tumors. I'm going to outline some of the morbidity that our survivors experience, and then share some of the clinical research and quality improvement-based strategies that we have ongoing here for these patients. And I'm relatively new to Seattle, and thanks to Doug for outlining some of my training, but I thought I would just share just a little bit about myself. So as Doug said, I did my Bachelor of Science at McGill University, my medical degree in Toronto, and then I finished my tour of Canada at the University of British Columbia, where I did my pediatrics residency and subsequently an endocrine and metabolism fellowship, which is really where I became interested in some of the comorbidities that our survivors experience and some of the late effects of the treatments that we give. But ultimately, I really wanted to be a pediatric oncologist and was very fortunate to have the opportunity to subsequently do a hematology, oncology, and BMT fellowship at the University of British Columbia. And that's where I really became interested in pediatric brain tumors and especially in early phase trials and novel therapeutics. And then I completed And then I completed a neuro-oncology fellowship at Nationwide Children's Hospital in Ohio, where I really honed in on phase 1 trials and early phase trial development in general. And then I was very fortunate to be recruited here to Seattle for my faculty position. And my interests in the pediatric neuro-oncology field are broad. First and foremost, I'm passionate about excellent clinical care for children with brain tumors. On the research side and academically, I'm interested in developmental therapeutics and early phase trials for those tumors for which we struggle to treat, and for those tumors with very poor prognoses. On the other side of things, in those patients who have excellent survival outcomes, I'm passionate about reducing some of the late effects and minimizing the morbidity of the treatments that we give. So the first part of my talk I've called Working Towards a Cure, and this is actually a photo that was put together by parents fundraising for a tumor called DIPG that I'm going to talk about, and these are actually all pictures of children who have passed away from DIPG. And this is a case. This is Olivia, and her parents very graciously agreed to share her picture and her story for the purpose of this talk and other talks. When I first met Olivia, she was a previously well 5-year-old, actually developmentally precocious, who initially presented to her primary care provider with headaches and an in-turning eye. She was diagnosed with strabismus, or a lazy eye, and given glasses. And her symptoms worsened, and she re-presented to her primary care provider, where appropriately an MRI was completed. At that time, she had marked ataxia and a cranial nerve 6 palsy. And you'll remember, if you remember your cranial nerves, you'll remember that cranial nerve 6 is the one that innervates the lateral rectus muscle. So in kids with cranial nerve 6 palsy, their eye is turned in. Olivia's MRI revealed a radiographic diagnosis of a diffuse intrinsic pontine glioma, or DIPG, and she was referred to the brain tumor program. So how common is DIPG? Well, it is a brainstem tumor, and in general, brainstem tumors make up about 10 to 15% of CNS tumors in children. And DIPG, while it is the most common brainstem tumor, is still relatively uncommon and a small proportion of all CNS tumors that we treat. And despite it being relatively uncommon, it represents about a quarter of CNS tumor mortality in children. This is a schema of the brainstem to illustrate some of the clinical features that we see in patients with DIPG. So this purple is the midbrain, the blue is the pons, and the green is the medulla. And DIPG is an intrinsic tumor of the pons, and how these actually present are really large, expansive pontine masses, or masses sort of that make the whole pons larger rather than separate masses to the pons. And when you think about it that way, it makes sense some of the clinical symptoms that we see, the most common being cranial nerve palsies. Oh, I just realized you can't see my mouse, sorry. See if this works. Well, I don't know how to fix that. Great. Well, you can see at the bottom, I'll just describe it. You can see at the bottom of the blue, so the pons where the base of the cranial nerve 6 originates, and cranial nerve 7. And those are the two most common cranial nerves that are impacted in children with DIPG. And really, DIPGs can spread into the midbrain and into the medulla, and actually can have metastatic disease anywhere in the brain and spine, and so can present with a wide variety of symptoms. But the hallmark signs are cranial nerve deficits, long tract signs, because the motor pathway runs right through that area as well, and ataxia. Other clinical features that we see are nystagmus, unilateral weakness, behavioral changes, and then a pathognomonic feature is unusual nighttime laughter. And DIPG has historically been a radiographic diagnosis, and there's you can see on your screen that there's an axial image on the left and a sagittal on the right, and DIPG is an expansile mass in the pons. It typically engulfs the basilar artery, and like I said, can really extend cranially or caudally through the rest of the brainstem and to other areas of the brain as well. It is hyperintense on T2, as you can see on the right side of the screen, and hypointense on T1. And like I said, historically, this really has been a radiographic diagnosis, and tissue diagnosis has rarely been used because of the risk of surgery, of biopsying in that region of the brainstem. Increasingly, we're using biopsy and histologic confirmation more and more, both to confirm the diagnosis and identify genetic aberrations that may define our therapeutic strategies, and also to allow patients entry into clinical trials. And we always recommend a biopsy in those patients where the diagnosis is uncertain based on imaging. The management for DIPG is limited, and we do use steroids for symptoms. We aim for the lowest possible dose because there are significant side effects of steroids, as you're all likely aware. Like I said, the role for surgery hasn't been clearly demonstrated, but we're using it more and more because biology may guide treatment. And in some patients, shunts are necessary to treat their hydrocephalus. The standard therapy is radiation therapy, and here in Seattle we use focal photon radiation, which is pretty typical internationally, dosed up to 59 gray. And in this picture you can see this is a patient with a radiation mask getting radiation to their head. And I will say that our patients generally decorate these masks, and they look a lot cooler than this one. So we see lots of Spider-Man and Superman and other really innovative decorative masks in our patients. And we really aim to start radiation as soon as possible as the diagnosis is identified. And unfortunately, the prognosis is very poor. The median survival for DIPG is 11 months, and less than 10% of patients survive beyond 2 years from diagnosis. And I'll draw your attention to this graph on the right side of the screen. The blue line is most patients with DIPG. And on the x-axis is time, and on the y-axis is percent survival. And so you can see by 2 years, there's almost 0% survival, and even much before that, most patients, there's very low survival. The red line and the green line are some genetic changes that may affect survival, which I'll talk about later. And there have been some epidemiological studies to try to understand some of that small proportion of patients that survive longer. And in general, these are kids who are younger. These are kids with longer symptom latency. And then there's some molecular features that confer both a worse and an improved prognosis in DIPG. So back to our case, so back to Olivia. You'll remember her in her Santa hat. So when we met Olivia, she was started on dexamethasone and had some symptom improvement. 2 weeks after her diagnosis, she began focal photon radiation and had some clinical and radiographic improvement after radiation. And we generally refer to this as the honeymoon period in DIPG, where most kids thankfully get some reprieve of their symptoms for an amount of time. Unfortunately, 7 months after her original diagnosis, she was found to have tumor progression, and her parents chose to enroll on a phase 1 clinical trial. And she had some tumor stability on that phase 1 trial, but 11 months after her diagnosis, her disease progressed and she stopped trial therapy. And then 13 months after her diagnosis, Olivia passed away peacefully at home with the support of the palliative care team and her family. And unfortunately, this is a very typical timeline for DIPG. This is not an anomaly. This is not an unusual case. This is actually a very typical case for this disease. And for me, this really highlights that we have to do better for these patients. And thankfully, we are really trying hard to do better. And there's been immense international efforts for this tumor recently in research, and lots of innovative therapies that have been under evaluation recently. We are evaluating therapies. We've looked at different radiation strategies because that has seemed to be the most effective therapy for DIPG. We've looked at hyperfractionation, giving bigger doses. We've even looked at giving bigger doses less frequently in hypofractionation. And unfortunately, there's not been any survival benefit with changing our radiation strategy. And a number of chemotherapy regimens have also been tried. So, for those of you familiar with oncologic treatments, we have lots of chemotherapy agents at our disposal for pediatric cancers. And in DIPG, oral chemotherapy, IV chemotherapy, combination chemotherapy, even high-dose chemotherapy with stem cell rescue have all been tried with, unfortunately, no durable response seen. Responses are about 0 to 20% in all of these trials. And more recently, our team here in Seattle published a combination chemotherapy regimen of bevacizumab, irinotecan, and temozolomide. And while these numbers may seem very poor to many people, actually a 16% survival at 5 years does signal that this drug combination may be helping at least some patients, but clearly isn't the cure for all comers of DIPG, and so we have to keep looking further. And along the way, while we're looking at these different therapeutic strategies, we've also been learning a lot about the tumor biology. And this is a wheel that I like from a cancer cell paper that was published recently showing some of the genetic changes that have been identified in DIPG. And the lime green is the most common genetic change that we see. It's called the H3K27M mutation. And for those of you who care for our patients in other parts of the hospital, you'll probably see this in our documentation. But there's this is a histone mutation, and there's other histone mutations in this dark green and in this purple color, and other non-histone mutations as well that we see in patients with DIPG. About 80% of patients with DIPG have some type of histone mutation, with the H3K27 mutation being most common. And with that mutation, we now classify these through the World Health Organization as something called diffuse midline gliomas of the pons. And there are more and more genetic changes that we are identifying in this tumor. And this is a beautiful paper that was published by Wu et al. In Nature Genetics, which shows some of the genetic changes in DIPG. And I'll draw your attention to where the red arrows are. So this is a PI3 kinase aberration, and then CDKN2A and CDKN2B. PI3 kinase is implicated in the mTOR pathway, which is a cancer pathway, and then CDKN2A and 2B are both in the cell cycle, and actually found that more than half of DIPG tumors that were studied as part of this study had genetic changes on these pathways. So what do we do with that? So how do we take that and turn it into a novel therapeutic strategy and help our patients? Well, when we identify these genetic changes either in the lab or in tumors, the next step is to actually translate them to a therapy that we may be able to safely use in children. And when we talk about clinical trials, we talk about phase 1, phase 2, phase 3, and you may have heard that language before. And a phase 1 trial is when a therapy is brand new. It's not been used in human beings. And in phase 1, the goal is to establish, is this therapy safe? And what is the maximum tolerated dose that that group of patients can have? And that's really when we talk about translating things from the bench to bedside. And I think that those genetic changes in the cell cycle and in the mTOR pathway are really good examples, because actually in other diseases, we have drugs that target both of those genetic changes. And so very smart people in our field put that together. And ribociclib actually targets the cell cycle pathway, and everolimus targets the mTOR pathway. And so they hadn't been used together before in children. And so the first step was to look at that drug combination together and do a phase 1 study to look at safety. And this was a study done through the CONNECT Consortia, which we're part of here in Seattle, looking at this drug combination in children with DIPG. And thankfully, they were able to establish that this drug combination was safe and establish what's called the maximum tolerated dose. And while survival wasn't the main outcome for this study or what this study was designed to assess, they did look at survival as well. And we have to interpret this with an abundance of caution, as I said, because this isn't how this trial was designed. But even so, we can see that at least in some patients, you'll remember my 11 months average survival that I quoted at the start, at 36 months, there were 37% of patients that were still alive. And while this doesn't appear to be something we can obviously immediately take to our patients, it's something that's definitely worth evaluating further. And this is significantly improved from the historical control survival data that was available at the time. And so the next step is to do a phase 2 study, which is designed to look at the effect of a new therapy. So once safety data is established and there's a maximum tolerated dose, we can take these agents to phase 2. And that's the trial that we're part of here, which is a molecularly guided phase 2 study of this same drug combination in children and adults with DIPG who have one of those genetic changes, either in the cell cycle or in the mTOR pathway in their tumor. And we'll likely be opening this trial very soon here at Seattle Children's. And while we're very excited about innovative strategies like this, we don't think that this is going to provide a durable cure for all comers of DIPG. And so we have to keep looking at other novel therapeutic strategies as well. And along the way, while that was all going on, there's been a lot of work in innovative immunotherapies. And this has been done through many institutions in the United States and around the world, looking at small molecules, something called vaccine studies, oncolytic viruses, and then something called CAR T cells, which I'm going to talk a little bit more about and is something that we do here at Seattle Children's Hospital. So what are CAR T cells? And I see lots of oncologists in the room who do know what this is, but CAR, or CAR, is chimeric antigen receptor. And what it is essentially is harnessing our own immune system to be targeted against a cancer. And if there's any immunologists listening, I apologize for this oversimplification of explanation of T cells, but essentially our T cells, as I explain to families, their job is to identify things that are foreign and tag them for destruction. And usually that's viruses. And cancer is not typically seen as foreign by our body because it comes from one of our healthy cells that made a genetic mistake and became a cancer instead of, for example, a healthy part of our brain. And in general, because they are not seen as foreign, the T cells leave them alone. And what CAR T cells do is actually have a receptor on somebody's healthy T cells for an antigen that we think or we know that tumor expresses, which is essentially now harnessing those T cells to go do what they would do and tag that attack that cancer for destruction. And this is a nice schema from a Nature Review paper, and thank you to my colleague Adam Lamble for sharing it, showing the antibody or the protein and how it is linked to a receptor on the patient's T cells, which is targeted for a tumor antigen on the surface of the tumor. So like I said, this is a targeted cellular therapy, and it recognizes surface antigens on the tumor, which are the targets. And importantly, it's independent of the major histocompatibility complex, which we talk about all the time for other areas of our cellular therapy program. And Seattle Children's has really been an international leader in CAR T-cell therapy for pediatric cancer for some time. And this is the pipeline of the CAR T-cell trials that have completed or are currently ongoing here at Seattle Children's. And the orange is CAR T-cell trials in leukemia and lymphoma. The green is CAR T-cell trials in solid tumors, and the blue is CAR T-cell trials in brain tumors, or our Brainchild program. And you can see here that we've had 4 Brainchild CAR T-cell trials. So these are targeting different CAR T-cells, or these are using different CAR T-cells in each of these trials, which I'm going to talk about a little bit. The first Brainchild study looked at HER2. I had a CAR T-cell product for HER2. The second CAR T-cell trial for brain tumors, Brainchild 2, targeted EGFR, and Brainchild 3, which is still open here for DIPG, targets B7H3. This is a schema of sort of what it's like to be on one of our Brainchild studies. And so patients come, the majority of our patients actually come from outside of Washington, and they come to Seattle for enrollment, where they undergo apheresis, which is a procedure that's done in our clinic. It's peripheral harvesting of the patient's T cells. And following that, they return home, and then their T cells are manufactured into CAR T cells at our Seattle Therapeutics infrastructure downtown. And the patients then come back to Seattle, where they receive CAR T-cell therapy, and we give the CAR T-cells what's called loco-regionally, and you'll hear that word used in conjunction with our trials. And we learned early on that the blood-brain barrier really beautifully protects the brain, and so some of the systemic therapies that have worked really beautifully for cancers like leukemia, including CAR T-cells, just aren't seeming to cross the blood-brain barrier in many patients. And so we're delivering these CAR T cells directly into the cerebral spinal fluid. And this is a little pictorial representation of what that is. Our patients have a little device in their head that I'm going to talk a little more about that allows us to deliver the CAR T cells directly into the cerebral spinal fluid. And this over here on the right side of the screen is the time course of being on our Brainchild 3 study for DIPG. After CAR T cells are manufactured, then patients receive CAR T cells every other week in our clinic for 2 months, and then they have the opportunity to go home, and depending on radiographic features and clinically how they've tolerated CAR T cells, they may come back and forth for further infusions in the future. And this is showing some of the patients that have, or all of the patients that have been treated on our B7H3 trial thus far. And this is something called a swimmer's plot. And I'll draw your attention, each of these rows is a different patient or subject. The orange is time before they have enrolled on our study. The yellow is enrollment to initial infusion. This is usually the time when apheresis is ongoing and then manufacturing. And then the dark blue is when they're receiving CAR T cells, and the light blue is time after receiving CAR T cells. And the top group are those who enrolled after progression of their DIPG, and the bottom group are those who enrolled prior to progression. And the black triangles are delineating the progression in the top group, and the red dots are delineating death. And you can see that the time course along the bottom, well, this was a phase 1 study and very much set up to establish safety of this product and not to evaluate survival. We are interested in how these subjects are doing overall. And like I said, with phase 1, we have to interpret survival data with truly an abundance of caution, as this is not how the study is designed. But we can see here, if you look at our 11-month time point on the bottom there, which is the average survival for DIPG, and even beyond 24 months, there seems to be a group of patients who are having a sustained response to this treatment. And even though there do seem to be some patients who are benefiting from this treatment, there are still most patients who are passing away from DIPG. And with that, we have to continue to evaluate further what therapy options may be available that would help even more of these patients with DIPG for a durable response. And we go back to the lab and we look at other target options for DIPG. And actually, in the lab, we found that there are 4 antigens that seem to be expressed on the surface of many of the DIPG tumors that we studied. And some of these are antigens that we had studied in our prior brainchild studies, prior brainchild studies. And we wondered if actually targeting more than one antigen at once may provide a more durable response for this tumor. So we go back to phase 1 because, again, this is a novel therapeutic strategy. And this led us to Brainchild 4, which is a quad CAR looking at targeting 4 antigens in the hopes that we can overcome antigen escape by actually targeting 4 proteins at once. And you can see this is a little pictorial representation of a quad CAR T cell. The red is one antigen, the orange is another, the green is another, and this little gray Pac-Man symbol is the 4th. And these are all on a patient's T cells and manufactured by our team here in Seattle. And with this product, we designed a phase 1 study. Again, it's loco-regional therapy given directly into the CSF. And we believe that this is the first in human study in any disease group to evaluate a quad targeting CAR T cell. So Brainchild 4 is, just like our other trials, is treating patients up to age 26. We have 2 arms. Arm A is those patients with DIPG, the tumor I mentioned, and Arm B is those other patients who have other refractory high-grade CNS tumors. This is showing the 2 different arms here with a pictorial representation of how we give CAR T cells loco-regionally, and we give dosing weekly for 3 weeks, and then a rest week, and then we do an MRI and clinical evaluation and use this information in order to establish whether they return for further CAR T cell therapy. And so far, we've enrolled 17 patients. On Arm A, we've enrolled 6 patients and treated 2. And on Arm B, we've enrolled 11 patients and treated 7. And this is an ongoing study, so we don't have results to share here, but stay tuned for those coming up. And I've talked a lot about this concept of loco-regional delivery of CAR T cells, which is directly into the CSF. And I thought rather than me continuing to try to explain what this means, one of our patients very graciously put together with our Markham team a video of CAR T cell therapy, and it's a very short video. Hopefully it will work here. That I think really beautifully demonstrates how this is done in our clinic.
CAR T-cell immunotherapy infusions. In this video, we'll show you what it is like to have an infusion of CAR T-cells. The infusion will happen in your child's clinic room. You are invited to help distract, hold, and interact with your child the entire time. Before the infusion, the T-cells are thawed for about 1 hour. During this time, your nurse will give your child medicines to help prevent side effects. We will apply a little numbing cream over the reservoir. You and your team will discuss the best plan to support your child during the infusion, including child life for distraction and support as needed. Preparing the work area. We start by cleaning the workspace. We then lay out a sterile drape and arrange all the necessary supplies in the sterile area. Before the procedure starts, we wipe off any numbing cream, trim any hair away from the area, and clean the area. Giving the infusion. After the area is ready, we put gauze around the reservoir and gently insert the needle into the reservoir.
2, 3.
Did it hurt?
Once the needle is inserted, we may collect a sample of spinal fluid. Next, we attach the CAR T cells to begin the infusion. The CAR T cells are infused over 1 to 2 minutes with a small amount of saline at the end to clear the tubing of any remaining cells. After the infusion. When the infusion is complete, we remove the needle, use gauze to apply slight pressure to the area, and clean up the area with wipes. You will stay in clinic after the procedure to watch for any signs of a reaction until your care team tells you it is safe to leave. During this time, your child can do whatever activities they enjoy. If you have questions, please ask your care team.
Thank you to that family and that patient and our team who put that video together. And really, it was actually made to help other families who are coming to Seattle for CAR T-cell infusions in our trials. And along the way, we also, we've now actually delivered more than 500 CAR T-cell doses to children with brain tumors here at Seattle Children's. And with that, we get a lot of requests to help other programs set up local regional therapy, either for CAR T-cells or for other novel CNS therapeutics. And we wrote this paper in the hopes that it would be helpful to our colleagues who are trying to understand some of the practical aspects of doing this safely. And this patient very graciously again agreed to be photographed for both this article and for this presentation. And this is demonstrating exactly what you just saw in the video for him getting CAR T-cells delivered into his Ommaya reservoir here. And we do this every day in our clinic. And in general, it's very well tolerated by our patients. We reviewed for the purposes of this more practical article all the patients that had been treated at that time, which was kids ages 2 to 25. They had a wide variety of CNS tumor diagnoses. Some of them had something called this Ommaya catheter, which this patient has, and some had actually shunts with a reservoir that we injected into. And at that time, we reviewed 307 CAR T-cell doses, and there hadn't been any CNS infections or need for shunt removals. We're also learning a lot about how to actually take care of the children who are getting these CAR T-cells and some of the side effects that they experience. And the most common side effects that our patients experience are headache, nausea, vomiting, and fever. And some patients have transient neurologic changes, which we think is related to immune infiltration of their tumor and actually a transient expansion of their tumor. This is an example of 3 patients with DIPG and the adverse effects that they experienced on B7H3, the B7H3 trial, which is our Brainchild 3 trial. And you can see here the pink is headaches, the blue is fever, and the purple is nerve disorders. And some of our patients, like the one on the top, have persistent symptoms. This patient has ongoing headaches, which is likely related to their tumor. But in terms of the side effects that seem to come on during CAR T-cells, which is the little Vs, you can see that it is temporal and related to the CAR T-cells. They seem to come on after the CAR T-cells and then go, which you can see in these little pulses here. And along the way, as we are conducting these trials and caring for these children, we're learning a lot about how to make our program even better. And as our trials have evolved, we have also evolved in how we include patients in these trials and how we conduct these trials. And we are now including patients with DIPG in all of our Brainchild trials. Originally, there was some concern, understandably, that with that pontine location of the tumor, that any expansion at all in that location would be too tight and may cause devastating neurologic injury. But thankfully, we were able to see that in general, they were relatively well tolerated, and we've included them again in our Brainchild 4 quad CAR T-cell trial. The period of time that families are required to stay in Seattle has also decreased from 8 weeks to 4 weeks in our current trial. And this is significant for the quality of life of these families, as you can imagine. And we were able to do this because we understand that for most patients, the most significant side effects seem to be happening with the earlier infusions. And in partnership with nurse practitioners on the brain tumor team and nurse coordinators, we have worked to develop resources that are used here at Seattle Children's for managing symptoms of patients on our trials. And these are some of the most common symptoms that we see and a guide for how we manage this in the hopes that we can standardize how we treat these patients when they present with symptoms after their CAR T-cell therapy. And so these are some of our preventative action in the top box there that we take in clinic, and then symptom management for outpatient, and then recommended symptom management for inpatient as well. And this is now available for anyone who's caring for our patients in the hospital. So I've talked about a lot of things so far. This is the summary of our story thus far. So I've talked about DIPG, which is a rare tumor, and unfortunately we've not yet identified effective treatments, but there's been remarkable international effort over the last few years to understand the biology of this tumor, and then several ongoing clinical trials to assess novel therapeutic strategies. And here at Seattle Children's, we are leading a novel approach to CAR T-cell therapy with our quad CAR T-cell trial for this disease. Thankfully, most of the tumors that we treat do not have the prognosis of DIPG, and in fact, actually most of the patients that we treat survive in the pediatric brain tumor program. And as we are improving our treatments for these tumors, it's important that we're thinking about our survivors and how we can mitigate some of the risk and late effects that they experience. So like I said, survival for most CNS tumors is improving, and actually tumor biology-driven therapies in other tumors has led to improved survival for many of these tumors, and actually in all comers for pediatric brain tumors, survival is greater than 70%. And actually in many tumors, it's significantly above that. In medulloblastoma, which is one of the most common tumors that we treat, the 5-year overall survival is greater than 70% in all comers, and actually in many groups of medulloblastoma, it's above 80%. And in CNS germ cell tumors, the 5-year overall survival is greater than 80% in all comers and actually greater than 90 to 95% in a major group of those tumors. And as survivors of CNS brain tumors increases, it's important that we think about their risk for therapy-related effects and therapy-related morbidity. And we're learning a lot about this. And I thought I would just illustrate with another case of a patient that I've taken care of. This is not her picture or her name, but this is her story. So Grace was a previously very healthy and straight-A student. She was hoping to become a neurosurgeon when I met her. At 16 years of age, she presented to her primary care provider with weight loss, amenorrhea, and visual impairment. She was actually diagnosed with anorexia nervosa at that time, and her symptoms persisted for about 6 more months, and she subsequently re-presented to her primary care provider with worsening symptoms, including polyuria and polydipsia. Her provider appropriately ordered an MRI of her head, and she was diagnosed with a bifocal germinoma, which is a type of CNS germ cell tumor. She underwent standard therapy for this tumor, which is multi-agent chemotherapy followed by radiation, and tolerated her therapy very beautifully. And she was cured, which is wonderful, but at what cost? And Grace, now more than 5 years from her CNS tumor diagnosis and treatment, suffers from cognitive impairment and memory challenges. She struggled to finish high school. She has panhypopituitarism and diabetes insipidus. She's now unfortunately obese. She has dyslipidemia and evidence of metabolic dysregulation, and she has secondary gonadal failure and worries about her fertility. And that case highlights for me that the therapies we give are not benign. And while we get very excited about curing patients, and that is really important, it is also relevant to think about what we're doing with these therapies and the side effects that they experience. And actually, radiation therapy and alkylator-based chemotherapy confer a significant increased risk for endocrinopathies like Grace experienced. And radiation therapy alone confers a significant increased risk for cognitive impairment when we compare to the general population. And some of this epidemiological data has actually been published by one of my colleagues here, Dr. Eric Chow, who leads our survivorship program. He's done a lot of great work to really describe some of the risk. And one of my interests is, how do we mitigate this risk? So how do we actually address this? It's helpful to describe it, and I think the next step is to figure out how we come up with strategies to change those statistics for our patients. And I've simplified it a little bit into what I think is a 3-step process that I'm trying to follow with my research. And step 1 is to look at pre-diagnostic morbidity. So what are the things leading up to their diagnosis with a brain tumor that ultimately impact their late effects and their experience as a survivor? Step 2 is to understand the in-tumor features. So what are the things we do in treatment? What are the patient factors that ultimately affect their late effects? And then step 3 is to look at how we can intervene and mitigate treatment or morbidity after they finish treatment. So step 1, reduce pre-diagnostic morbidity. So a program through the United Kingdom called HeadSmart has done some really great work trying to understand this, and they described that the median time from symptom onset to diagnosis of a brain tumor was 12 to 13 weeks. We call this the time to diagnosis. And they looked at a variety of European countries, and there was variability in terms of the time to diagnosis. And they actually were able to describe that perioperative morbidity was increased in children who presented after a prolonged symptom interval. And actually, the prolonged symptom interval was associated with increased cognitive deficits in the long term when they followed patients through survivorship. I became interested in some of these factors, but also about endocrine dysfunction and vision loss, which is currently as well under evaluation with this group. And at the same time, we started to do some similar work, and we looked at the impact of time to diagnosis in a multi-center study in children with CNS tumors. And we reviewed almost 200 kids who had pediatric brain tumors and looked at the median time to diagnosis, which was 62 days, with a very wide range, as you can see there. And overall survival was, of course, impacted by their diagnosis. So this graph, each color is a different type of brain tumor. And that's not surprising to us. We know this already. But when we controlled for diagnosis, overall survival was also associated with time to diagnosis as well. And there was evidence that it was associated with risk for endocrinopathies and vision dysfunction. Step 2 is to understand the prognostic factors during treatment. And an example of this is a project we're working on through the Childhood Cancer Survivorship Study. And we're looking at gonadal failure and infertility as reported by survivors of childhood brain tumors. And for those of you not familiar with the Childhood Cancer Survivorship Study, it's a really wonderful initiative. It's multi-center, housed out of St. Jude's, and it has thousands of cancer survivors and their reported data in the long term. And so we queried the database with two aims: to describe the incidence of primary gonadal failure in survivors of CNS tumors, and then also to describe infertility. And we looked at these in conjunction with their tumor type, what treatment they received, radiation, chemotherapy, and then other factors that we think, patient factors that impact gonadal function, like pubertal status and age at the time of receiving their treatment. And that work is currently underway. We're also doing some work locally here in Seattle. And here in Seattle, we have a robust fertility preservation program, and we are very fortunate to be able to offer fertility preservation to all of our cancer patients. And this is led by my colleague, Dr. Tyler Ketterall. And him and I partnered together, and we're interested in some of the prognostic factors during treatment that affect fertility, and looking at those in real time. And we know that this schema on the right here is showing normal folliculogenesis in the oocyte. And we're doing a project right now to evaluate AMH and gonadal function in the early post-treatment window to assess whether there may be an actual fertility preservation window that exists after starting treatment. And this interest stemmed from some adult data that demonstrated that this may be true, although it hasn't been evaluated in children and hasn't been evaluated in CNS tumors. And we think this is important to ask because while we have a robust fertility preservation program, many centers don't. And if there's an opportunity to offer fertility preservations to patients after they've started treatment, we want to be able to offer it. And this is a schema demonstrating normal ovarian reserve over time with age on the bottom. And this top line here, and I know you can't see my cursor, is the normal. And the little smaller line below shows what happens in radiation or chemotherapy exposure with rapid loss of follicles. And this is our pictorial demonstration demonstrating that, where instead of going through folliculogenesis, the oocytes actually undergo atresia and apoptosis and die. And we wondered, while we know that before receiving chemotherapy and radiation therapy, there's an option for fertility preservation, but is there a fertility preservation window just after starting or just after finishing? And that's what we're trying to evaluate through this study. Step 3 is to intervene after they finish treatment and to mitigate post-treatment morbidity. And there's been quite a lot of work in this area in other centers. And many of you are likely aware that for things like type 2 diabetes and the metabolic syndrome, once a patient is diagnosed with these things, they're at very high risk for some of the secondary complications like ocular complications, renal and cardiovascular complications. And it's really challenging to reverse at that stage in any patient, even outside of the setting of cancer. And when these things are identified earlier on in the setting of insulin resistance or even sooner, it is much simpler to reverse some of these complications. And so we're very passionate about finding ways that we can identify these things as early as possible in our survivors in order to hopefully save them some of these additional morbidity down the line. And there's been some great work describing this through the Childhood Cancer Survivorship Study, and then through the Candicide Initiative for pediatric brain tumors specifically. And some of the work that's come out is that there may be some markers that are better than our average glucose, hemoglobin A1C, and insulin in terms of being early identifiers of metabolic dysregulation. And there was some good data suggesting that things called adipokines, which includes adiponectin and leptin, may actually be more sensitive. And so we sought to evaluate that. And we examined serum adiponectin as a marker of adiposity, and we compared survivors of CNS tumors with controls. These controls were recruited from the orthopedic clinic and were otherwise healthy children. And we looked at adiponectin and leptin in terms of anthropometric measurements and fat mass percentage. And we found a signal that adiponectin was actually significantly associated with total and central adiposity in survivors. Now, this study had limitations, and these patients were all more than 5 years from completion of their tumor-directed therapy, so challenging to know exactly when those markers might have been most helpful. And they didn't evaluate the adipokines in conjunction with the rest of the components of the metabolic syndrome, like lipids and hemoglobin A1C. And that led us to a study that we're working on now, and this is in partnership with several colleagues in the Division of Endocrinology here, as well as in our division. And we're looking at adiposity assessment and metabolic dysregulation in survivors of childhood brain tumors. And we're trying to understand the relationship between these adipokines and adiposity or body composition, as well as the relationship between these things and the components of the metabolic syndrome. And so we're looking at adiposity and the components of metabolic syndrome in patients who have just completed treatment for childhood brain tumors within the first 5 years to try to understand, again, which markers may be the most sensitive early on to evaluate this. And we're describing these abnormalities in terms of the treatment that they've received, the age of the patient, and other factors as well. And one of the things that's really challenging, and I learned this more when I was training in endocrinology, is actually to measure body composition and adiposity in children. And this is something that many of you who are listening may be more familiar with than me. We actually struggle to have adequate or accurate measures of body composition in pediatric patients. And the gold standard is actually DEXA scanning, which is a really great way to get robust data on body composition. And there's some downsides. It's not always readily available, especially for research, and it does expose patients to radiation. And Kate P. Hooker, who many of you likely know is our division chief of endocrinology, for some other body composition work outside of cancer therapy, purchased something called a bod pod, which overcomes some of those barriers for studies like ours. And it's got a bit of a silly name, and I know this picture looks a little bit silly as well, but it uses air displacement plasmography to determine body composition, and it's no radiation exposure or other things for our patients. It takes about 2 to 3 minutes, and so far the pediatric patients have really been tolerating it well, even though this guy looks very silly in his swim cap in there. And we're using this to measure body composition and adiposity and compare these to these metabolic markers that I mentioned as part of this study. So what do we do with this information? I think there's a little bit when you present kind of studies like this of like, so what? How are we going to help patients? We're gathering all this information. What are we going to do with it? And my hope is that this 3-step approach to establish and understand both the pre-diagnostic, in-treatment, and post-treatment risk factors for late effects will help us to develop robust clinical practice guidelines that would be really aimed at morbidity mitigation for this group of survivors. And I'm especially interested, as I've mentioned, in metabolic dysregulation for our survivors and in gonadal function and infertility for our survivors. And I really hope to translate our findings into guidelines that could be used not just here while they're in the oncology clinic, but by their primary care providers and through adulthood, with not just strategies for monitoring, but actually intervention strategies along the way. And I think we can do it with a lot of great collaboration from other experts, and I really hope that we will. So where's our story at? So we've talked about a lot of things, and in those tumors where survival is excellent, which is most of the tumors that we treat, it's really important that we work to minimize morbidity in our survivors. And I think we can do this through minimizing pre-treatment morbidity, identifying risk factors and understanding the risk factors during treatment, and identifying and mitigating the late effects as they occur. So back to our objectives, if you remember that slide all the way back. So we've talked about DIPG, which is a rare tumor. It's got some classic clinical features, radiographic features, and unfortunately a very poor prognosis, and we've not yet identified effective treatments. There have been efforts that have resulted in a significant improvement in the understanding of the biology of this tumor and led to some really really fascinating new therapeutic strategies. And here at Seattle Children's, we're leading a novel therapeutic strategy for CAR T cells with a quad targeting CAR T cell therapy in our study Brainchild 4, which is currently open. And in our survivors, there's still significant morbidity experienced. And we are working to understand gonadal function and metabolic biomarkers to inform what we hope will be really useful and practical clinical practice guidelines for this group of patients. I have many people that I really need to thank, and they don't even all fit on this slide. First and foremost, I have to thank the brain tumor team, which is really an exceptional team here at Seattle Children's Hospital, led by our medical director, Sarah Leary, who's also been such an important mentor for me as I've been starting here as faculty. I have to thank all of my partners, Nick Batanza, Aaron Crotty, Dan Runco, and Amy Sato, who all wholeheartedly support this research and care for these patients together with me. We have an incredible group of nurse practitioners and nurse coordinators who actually provide most of the care for some of these brainchild patients and are really great partners in caring for these children. Allison Thompson is the coordinator for our brainchild program and really is so dedicated to these patients and families and it facilitates all the work that we do here with those patients. And the brain tumor team is very much not just neuro-oncologists. And if you ever come up to Forest A7 on a Wednesday afternoon, you'll see us all there. We work very closely with our partners in neurosurgery, neuroradiology, neuropathology, rehab medicine, endocrinology, neuropsychology, and it's really a team effort, a multidisciplinary effort to care for these patients and to run these studies. I also have to thank Seattle Therapeutics, which really has done a remarkable job in building this infrastructure for CAR T cell trials here in Seattle Children's and facilitating the running of these trials and actually the manufacturing of all of these products, which is incredibly challenging. Within the actual Seattle Therapeutics production and trials, we have a number of people that I should thank and don't have time to name all here. Here at Seattle Children's, we have a CRA and CRC group led by Matt McQuivy for our brainchild studies, who also do incredible work in facilitating these trials. And along with them, we have a team of research nurses led by Victoria Weiss, who contribute so much to how we care for these patients on these trials as well. I have always been very fortunate to have really excellent mentorship and collaboration through all of my training and through faculty here, both in our division at Seattle Children's, but also in other divisions outside of ours, and in institutions beyond Seattle Children's. And I have to really thank all of the mentors who've supported me to get to where I am right now. And then, of course, my funding sources. I have a clinical research scholars program grant right now through our department for some of my work. I have a CCSS Career Development Award and funding from the St. Baldrick's Foundation. And most importantly, I have to thank all of the patients and families. Truly, it's a privilege to learn from them and to care for them every day. And thank you to all of you for listening to this talk.
Hope this is on.
Well, that was fantastic.
It's an unbiased review. So we'll start with questions in the audience, and then we may have some questions online. Anyone in the audience have a question? All right, I'm going to ask a question. On brand, I have a question about clinical trials. Phase 1 studies are really hard to do. Phase 2 studies are really hard to do. What level of activity would you want to see in phase 1? You described a variety of phase 1 studies that would lead you to want to do a phase 2 study.
Yeah, thank you for that question. And I think it's a challenging question to answer because we have to be so careful when we think about effect of a therapy that's being studied in phase 1, when that is really not how that trial was designed. It was not designed to assess effect. And so I think we really rely on comparison to historical control data. And actually in DIPG until recently, we didn't even have really robust historical control data with which to compare. And so we've been trying to understand whether it's 30% or 40% or where our marker is in survival that would allow us to translate into phase 2. And right now what we're relying on is signals of true safety in phase 1, and then some signal of effect, at least in a portion of patients that are allowing us to translate things into phase 2. But we haven't been able to come up with like a cutoff number really for that disease. It's a really good point that
At
we.
least Connect had a cutoff, right, that allowed them to do that phase 2 study we're going to participate in.
Connect 2109A.
Yeah, the study.
Yeah, for that study, the cutoff was 20% for I believe it was 2-year survival that allowed translation into phase 2. Mm-hmm.
Questions? How about online? Emily, do we have any questions online?
Nope, the online group is really quiet.
What? This is not a quiet group. Someone.
Thank you so much. That was just so absolutely outstanding. So for those of us who don't do hematology oncology, are there words of advice that you can suggest to not delay diagnosis in these patients with brain tumor?
Thank you for that question. And I think it's so challenging because, I presented 2 cases, both of which had a misdiagnosis early on of something that is so much more common in children. And for example, in Olivia's case, which she was diagnosed with strabismus. Strabismus is infinitely more common than DIPG, and we're certainly not advocating for every pediatrician and primary care provider to start doing MRIs in every kid with a headache or every kid with what looks like strabismus. And I think what I think our job to do on the brain tumor side is to educate what are the red flags. So what are the true things that as a primary care provider, so in Olivia's case, she began to develop really severe headaches and ataxia. And so the primary care provider appropriately did an MRI at that time. When she was entirely well with strabismus, I would argue that it was appropriate that there wasn't an MRI done at that time. For my second patient who had primary amenorrhea and change in school performance and weight loss, that patient again was diagnosed with anorexia nervosa. And I think the red flag for that case was she had pretty remarkable polyuria and polydipsia. And that was really leading to her school performance change because she was up all night drinking and peeing. And so she was so tired and wasn't doing well at school and had previously been a straight A student. I don't fault the primary care provider for thinking about an eating disorder in a very high functioning teenage girl because that is more common than a CNS germinoma. And so I think it's about paying attention to what features of that case are different than average and some of the red flags. And there's some obvious ones like symptoms of obstructive hydrocephalus are always an emergency. I think that a focal neurologic deficit that isn't going away should always be investigated further. And then I think it's our job as pediatric neuro-oncologists to facilitate education of our trainees and of our primary care providers to help with that.
Thanks.
I do have 2 questions online. One from James Polakar. He says, can you talk about Brainchild Bio?
So BC Bio is a biotech company that was recently created, but I am not part of that. So I would prefer not to talk about that and leave it for people who truly can answer those questions.
Maybe James Polakar wants to come off mute and talk about Brainchild Bio.
Getting a resounding no from talking about it in the room.
All right, other question?
So the next question comes from Kevin Baker. He says, for the Brainchild studies, how many infusions does a typical patient receive for a typical treatment course?
Great question. It's variable. So in Brainchild 4, patients get 3 infusions in the first course and then may return for following infusions. And it's too early in that study right now to quote averages, where it's still a very new study and we're very much actively treating patients. In Brainchild 3, for patients with DIPG, they got 4 infusions in the first 2 courses, and for non-DIPG, they got 6 infusions in the first 2 courses and then returned back and forth. Many of our patients do come back and forth every month for several months afterwards, but it is variable. So we have a patient who has been on our Brainchild study. We have 2 patients who've been on our Brainchild 3 study for more than 2 years, coming back and forth for infusions. And then we have other patients who either due to side effect tolerability or due to rapid disease progression do not get infusions beyond those first 2 courses. So it's a wide range.
All right, any other questions? All right, if not, thank you very much for everyone who is online and here in the room. You'll be getting a reminder about the evaluation, so thank you for filling that out.